Hello and welcome. My name is Dr. Sherif Negm. I'm a professor of obstetrics and gynecology at Cairo University, and today we will be talking about three important topics, namely preterm labor, postterm pregnancy, and fetal macrosomia. The first topic is preterm labor, and it is defined as birth after fetal viability, that is determined to be 24 weeks, but before 37 completed weeks of gestation. Roughly, it can be divided into early preterm labor and late preterm labor. Early preterm labor is labor that occurs before 32 weeks of gestation, while late preterm labor is one that occurs between 32 and 36 weeks of gestation. This distinction is important because it has prognostic value. Babies born before 32 weeks of gestation usually have a worse outcome with higher incidence of neonatal morbidity and mortality, with higher incidence of RDS and necrotizing enterocolitis and intraventricular hemorrhage. Regarding the incidence and risk factors, it occurs in about 5 to 10% of pregnancies. In 50% of cases, there is no identifiable etiology, making preterm labor in most cases an unpredictable event. There are, however, several risk factors: obstetrical, medical, and environmental. Obstetric risk factors include a previous history of preterm labor, premature rupture of membranes, which results in intrauterine infection and uterine contractions, intrauterine growth restriction, and intrauterine fetal death. Cervical incompetence, as in cases of recurrent pregnancy loss. Short cervical canal, less than 2.5 centimeters, as measured by transvaginal ultrasound at 20 to 24 weeks of gestation. As we know, we usually measure the cervical length at the same time as we do a mid-trimester anomaly scan, and if we do a cervical measurement transvaginally at that time, we can detect many cases that are at risk of preterm labor. Uterine anomalies such as septate and bicondyloid uterus have a higher risk of having preterm delivery because of their associated abnormalities in the cervix resulting in cervical incompetence. Uterine overdistension, as in cases of twins pregnancy and polyhydramnios, result in a higher incidence of preterm delivery. Medical factors and conditions such as infections, especially those of the urinary tract, severe cystitis and pyelonephritis because of the ensuing fever may result in contractions resulting in preterm delivery. Lower genital tract infections, especially those involving bacterial vaginosis, have been implicated in the occurrence of preterm rupture of membranes and subsequently preterm labor. Medical conditions such as uncontrolled hypertension, uncontrolled gestational diabetes, they may necessitate an induced preterm delivery, termination of pregnancy before term, in order to save the mother's life or to mitigate the seriousness of the medical conditions. Environmental and behavioral factors such as successive short interval between deliveries, less than 18 months. This was based on several retrospective analytical studies, but many patients have successive pregnancies with short interspacing and with no occurrence of preterm delivery. Smoking and substance abuse. This is also a retrospective studies, probably because smoking and substance abuse may be associated with intrauterine fetal growth restriction because of placental insufficiency. Excessive physical activity, competitive sports, especially those that are associated with contact, such as football and any competitive contact sports such as basketball, in which trauma to the abdomen may be encountered, also may result in preterm delivery. So what are the complications of prematurity? Of course, because the baby is born prematurely, many of the organs and systems are still not completely mature. And a good example of those are the vessels, especially the vessels inside the brain, so that many babies born prematurely are prone to develop intraventricular hemorrhage. Also, the lungs are immature because of immaturity of the alveoli, because the left sphingomyelin ratio is still low and there's not enough surfactant in the lungs, so that they are more prone to develop respiratory distress syndrome. Also, neonatal sepsis is more commonly encountered in infants born prematurely because of the immaturity of the immune system, and may be iatrogenic because of the handlers, the nurses and doctors may transfer infection from one baby to another in the neonatal intensive care facility. Necrotizing enterocolitis is also may be encountered in premature infants because of immaturity of the gastrointestinal symptoms. Retinopathy of prematurity, whereby the retina may be damaged by exposure to light in the neonatal intensive care facility. For this reason, any baby inside the NICU that is subjected to phototherapy or anything involving visual or light exposure for prolonged periods should wear protective masks in order to protect the eyes from exposure to the phototherapy. Also, sometimes excessive oxygenation may result in also retinopathy of prematurity because of the improper ventilation. Bronchopulmonary dysplasia may also be encountered because of immaturity of the lungs. Cerebral palsy. Several studies have found that babies born prematurely, especially before 25 weeks of pregnancy, are more prone to develop cerebral palsy later in life, even if they have a normal outcome after delivery and are saved because of the effective NICU intervention. Many of them will develop cerebral palsy at a later time. So how can we predict preterm labor? This is, as you can understand, it is a difficult thing to predict prematurely or beforehand. One of the conditions or one of the giveaway symptoms would be repeated abdominal cramping with watery vaginal discharge, especially if these abdominal cramping have the characteristic features of labor, in which they are of successively shorter interval between each contraction and successively higher in amplitude or duration, suggesting the onset of preterm labor. Also, as I stated before, transvaginal ultrasound is very helpful in detecting patients at risk of going into preterm labor, and we do this by measuring the cervix routinely for all pregnant women during the second trimester when we're doing a second trimester anomaly scan. If you find a short cervical canal less than 2.5 centimeters after 20 weeks pregnancy, then this patient is considered to be at high risk of having a preterm labor and should be managed as such. Also, another method of detecting or predicting preterm labor is to detect fetal fibronectin in the cervical discharge, and we'll talk about that in after one or two slides. This is an ultrasound image, transvaginal ultrasound, and you can see here this is the bladder, and you can see here this elliptical structure. This is the baby's head, and you can see here this is the cervix, this is the posterior lip, and this is the anterior lip, and this is the measurement of the cervical canal from the internal os to the external os, and it should be, this measurement should be more than 25 millimeters to be deemed as a normal cervix. You can see from this image here that the cervix is substantially shorter. You can see this part here, this triangular area. This is called the funneling of the cervix. You can see the baby's head, and you can see between the calipers, this is the functional part of the cervix. This is the remaining part, and as you can see, it is substantially shorter than in the previous slide. So this patient has a funnel of the cervix. It is a Y-shaped cervix, as you can see here, and this indicates that this patient is at a higher risk of having preterm delivery. Another method of predicting preterm labor is to measure fetal fibronectin. Fetal fibronectin was found to be present in the cervical secretions very early before 22 weeks and late in pregnancy after 34 weeks as the pregnancy approaches term. So if you find fetal fibronectin cervical secretions more after 20 weeks, this may be an indication that this individual is at risk of preterm delivery. A positive result is more than 50 nanogram per deciliter, may be indicative of either preterm rupture of membrane or cervical dilatation, indicating that the individual is at risk of preterm labor. So how can we prevent preterm labor now that we have detected cases of preterm labor? One of the most commonly used method nowadays is to give the patient daily transvaginal progesterone 200 milligrams from 20 weeks of gestation onwards, and this was found to reduce the incidence of preterm delivery. Another strategy or intervention is cervical cerclage, similar in fashion to what we use in cases of recurrent trimesteric abortion. We can also use cervical cerclage if you find that the cervix is short at 20 weeks, and this was found also to reduce the risk of preterm labor in patients with a short cervix and previous history of recurrent trimesteric miscarriage or repeated early preterm labor. So what are the management options in patients with established preterm labor? The first thing we have to do is to confirm the diagnosis the patient is actually in preterm labor. And this is usually the labor between 24 and 37 weeks, as we have stated before. We have to document that the patient is actually having uterine contractions, and this can be done by CTG or cardiotocographic evaluation. And we have to record at least 4 contractions in a 20-minute period. And as we said before, these contractions have to be rhythmical and increasing in frequency and duration and amplitude. These contractions also have to be associated with cervical changes, in which there is progressive cervical effacement more than 50% and dilatation more than 2 centimeters. So if we have a patient that has gone into preterm labor, what can we do for them? The first thing is hospitalization, in which the patient has to rest in bed and have to take sedatives and adequate hydration, together with monitoring of uterine contractions with CTG. If there is any correctable cause, such as urinary tract infection, then by all means we have to try and treat this infection, because this way may help the contractions to subside or stop completely or by themselves. Ultrasound examination, of course, is very important in order to confirm the gestation age, to confirm the fetal well-being, that the baby is not hypoxic, and the presentation, as well as the placenta localization and the amount of amniotic fluid. In other words, to confirm the gestational age, the weight of the baby, as well as the presentation and the site of the placenta. Evaluation of fetal well-being is also important, because if the baby is hypoxic, as seen from Doppler examination, then we may be tempted not to give this patient tocolysis or stop the contraction, but rather deliver her prematurely to save the baby. We have to try also to diagnose risk factors for preterm labor, such as polyhydramnios, macrosomia, and twins, which may be the culprit or the cause why the patient has gone into preterm contractions. Another important strategy, if the patient is going into preterm labor, we have to try and minimize the risks of prematurity on the newborn infant. And there are 2 important things that we can do. The first thing is to give this baby or the mother prophylactic antenatal intramuscular corticosteroids, because these corticosteroids were found to enhance the fetal lung maturity and reduce the risk of RDS, respiratory distress syndrome. It also decreases the risk of intraventricular hemorrhage and necrotizing enterocolitis, and it is usually given either in the form of betamethasone, 12 milligrams, and a single dose repeated twice, or dexamethasone 6 milligrams, 2 doses repeated 2 times. It is important here to give the patient either betamethasone or dexamethasone because they cross the placenta freely and can reach the baby and cause their beneficial effects. We should not give the mother prednisone or prednisolone because this does not cross the placenta. 90% of prednisone and prednisolone is metabolized in the placenta, and therefore no beneficial effect will reach the baby. Another intervention which was found to be of value is to give the mother antenatal intravenous magnesium sulfate, similar to the dose given in patients with severe preeclampsia. And here the benefit was found that it reduces the risk of cerebral palsy in neonates, especially if they are going to be delivered extremely prematurely before 28 weeks. So it has a neuro or protective effect. Tocolytic therapy, what is meant by tocolytic therapy is therapy to try and delay the onset of labor or to prolong pregnancy in order to allow for the benefit of the administration of intramuscular corticosteroids to take effect, because the corticosteroids, in order to be beneficial, they have to be given at least 24 hours before the baby is delivered in order so that the baby has the maximum benefit. Also, if the mother starts contracting or going into preterm labor in a primary healthcare facility or facility without neonatal intensive care, then giving her tocolytic therapy will give us time to transfer her to a center prepared for neonatal intensive care. What are the contraindications for tocolysis? Obviously, what are the tocolytic agents that can be used? There are several tocolytic drugs that can be used to delay or postpone pregnancy. And as you can see, because there are a large number of tocolytic agents, none of them is completely perfect. The most commonly used tocolytic agent are the beta mimetics, especially ritodrine. This is the most commonly used one because it is routinely available, it is inexpensive, and it is very effective. But it has the side effect in that it is actually a beta mimetic, and as such it induces tachycardia, and sometimes it causes hypotension. So it is contraindicated in patients with overt thyrotoxicosis, cardiac patients, of course, because the patient may go into heart failure and pulmonary edema, and also diabetic patients because it may increase the blood glucose level and the patient may go into a diabetic coma. Another important drug are calcium antagonists such as nifedipine, and these were found to be very effective in delaying labor with fewer side effects than beta mimetics. Mainly they cause some hypotension and facial flushing, and but they are much safer in cardiac patients than beta mimetics. Oxytocin receptor antagonists are also safer than beta mimetics, such as atosiban, because they block the oxytocin receptor completely, rather than inducing the side effects of beta agonists. And in this case, their side effects are much less and they're more effective than beta mimetics, but they are more expensive. So if a patient actually goes into labor, what are we going to do? Well, the mode of delivery will depend upon the presentation as well as our expertise. If you have a vertex baby, then vaginal delivery may be allowed, but you have to bear in mind that the baby is very fragile and the blood vessels, especially inside the brain, are still very, very fragile. And so you should avoid rapid compression and decompression of the skull by gradual delivery of the baby. And after delivery, of course, you have to keep the baby's head up in order to prevent as much as possible intraventricular hemorrhage, and you have to be very gentle while you're delivering the baby because the baby is still very, very fragile, and as this may cause trauma or fractures to the baby. In breech presentation, the problem with the breech presentation in a preterm infant is that the breech is much, much smaller than the size of the head, and so these babies are more prone to a retained aftercoming head, resulting in a situation where you have to do manual jaw flexion, shoulder traction in order to physically extract the breech from an incompletely dilated cervix. And as you can imagine, in such a situation, the outcome for a preterm infant, especially if he weighs less than 1,500 grams, is going to be very bad, with a high incidence of neonatal morbidity and mortality. Of course, intrapartum continuous fetal monitoring is essential, with special attention to abnormal fetal heart rate patterns. And you have to bear in mind that in a preterm infant, you're more prone to find abnormal fetal heart rate patterns than in a term infant. So more prone to have cesarean section for what seems to be abnormal fetal heart rate pattern. Of course, if you have a breech presentation, it's always safer to deliver these babies by a cesarean section, given the high possibility of um, uh, complications such as retained aftercoming head. Next, we'll talk about postterm pregnancy. And as you can see from this chart, you can have an early term pregnancy between 37 weeks and 38 weeks and 6 days, a full term pregnancy between 39 weeks, 40 weeks and 6 days, a late term pregnancy from 41 weeks to 41 weeks and 6 days, and what is defined as a post-term pregnancy, which is more than 42 weeks. So the definition of post-term pregnancy is a pregnancy that continues more than 42 weeks after the first day of last menstrual period, that is more than 294 days. What is the incidence? The incidence, it occurs in about 6 to 12% of pregnancies and may extend, 6 to 12% of pregnancy may extend into the post-term period. Post-term period more than 294 days. The incidence, however, is declining in the last few decades owing to the policies of pregnancy, termination or delivery before reaching 42 weeks gestation in order to avoid the risk and complications of post-maturity. So what are the causes of preterm or post-term pregnancy? Most cases are idiopathic with no identifiable etiology. In at least 20 to 30% of cases, pregnant women, 20 to 30% of cases of pregnant women, you'll find that their dates are not very reliable, so that actually they don't have post-term pregnancy, they just have wrong dates, and this has led us to calculate that the pregnancy is actually post-term, while in actual fact this is not. Some cases they do actually have post-term pregnancy, such as in cases of fetal anomalies such as anencephaly due to absence of fetal hypothalamic-pituitary regulation. But of course, this kind of abnormality, anencephaly, very, very rare reaches post-term pregnancy nowadays, because many cases with the advent of ultrasound and the widespread use of ultrasound in obstetric clinics, most cases of anencephaly are usually diagnosed very early on in pregnancy at around 12 to 14 weeks and are terminated at an early gestational age, so that very few of them actually reach a situation where they get to a post-term pregnancy. So how can we diagnose post-term pregnancy? Accurate pregnancy dating supported by the first trimester ultrasound. These are the gold standard for diagnosing of a post-term pregnancy. So the first thing we have to do is look at the patient's file, make sure that she did an ultrasound very early on in pregnancy. If this is not available and her dates are not reliable 100%, then most probably this is not a post-term pregnancy. However, if the patient has good records, she has maintained them themselves, or they're present in the hospital, indicating that she did an ultrasound very early in pregnancy, it's around 5 to 6 weeks, and the gestational sac was seen at that time, then this is a good indication that the patient is actually does have a post-term pregnancy. So what are the risks of post-maturity? There is an increased risk of perinatal mortality. large for gestation. The baby becomes much larger. It will continue to grow in about 80% of cases, resulting in what is known as fetal macrosomia, and this results in a high risk of difficult vaginal delivery, resulting in maternal and fetal traumatic birth injury, especially shoulder dystocia and Erb's palsy. Um, Placental insufficiency, this occurs in 20% of cases, what is known as placental aging and placental senescence. This will result in fetal dysmaturity syndrome and intrauterine growth restriction. And of course, there is a high incidence of cesarean delivery in these post-mature infants because of either a large for gestation age baby or because of the intrauterine growth restriction ensuing after 40 weeks. This is what the baby looks like if it is born after 42 weeks. This is what is known as the post-mature infant. As you can see from this image, this is a baby born at around 43 weeks of gestation. There's thick viscid mucus coating the skin with a discoloration and wrinkling of the skin. You can see the wrinkling over the legs there. And also, if you examine the baby closely, you find that the nails have overgrown the fingers. He has overgrown fingernails. Of course, also there is sometimes the baby opens his eyes and there's overgrowth of the head hair. Management of preterm of postterm pregnancy. The first thing is that you have to confirm the gestational age. Second, you have to evaluate the fetus if it is okay or not. Daily fetal movement count and biweekly non-stress test. Ultrasound, of course, is the mainstay for evaluation of the fetal well-being in order to determine the biophysical profile, the umbilical artery Doppler, and the estimated fetal weight of the baby, as well as the amniotic fluid index, also to exclude the presence of any congenital abnormalities. When should we deliver this pregnancy? It can be done either by induction of labor or by cesarean section, depending on the situation. If the pregnancy is still between 40 and 42 weeks and the baby is fine with normal weight, normal amniotic fluid, normal Doppler, and the mother's condition is also stable, then we can wait until the baby or the mother reaches 42 weeks. However, if the fetal condition deteriorates and you find that the baby is suffering from intrauterine growth restriction, then you have to intervene at an earlier gestation. After 42 weeks, then you have to deliver the baby, whether or not it is, even if the baby appears to be normal, then, and you're absolutely sure that the pregnancy has reached 42 weeks, then you have to deliver the patient, even if the baby is normal with normal Doppler. Of course, during the surveillance, if there is evidence of placental insufficiency, oligohydramnios or umbilical artery Doppler changes, then you have to deliver the baby at any gestation age, regardless of the gestational age. Fetal macrosomia, this is our last topic, and it is usually related to postterm pregnancy. The definition incidence, macrosomia, that means it is defined as a newborn who is significantly larger than the average. Usually the exact definition of fetal macrosomia is an estimated birth weight that is 2.5 or 3 standard deviations above the normal or more than 95th centile for gestation. And this affects about 5% of neonates. The risk factors, all the risks and complications occur significantly more. Of course, as you can imagine, the bigger the baby, the more risk of complications that are going to happen. And the cutoff value for us is about 4.5 kilograms, so babies that are more than 4.5 kilograms by ultrasound are deemed to have a higher risk of complication than those below 4.5 kilograms, and this usually occurs in about 0.5% of newborn infants. One of the most important risk factors is maternal diabetes. This is the most important, most common risk factor because in uncontrolled diabetes, of course, there is maternal hyperglycemia, and this results in new fetal hyperglycemia, and the fetal hyperglycemia will result in fetal hyperinsulinemia. And as you know, the fetal insulin acts as a growth hormone, resulting in overgrowth of the baby, resulting in fetal and neonatal macrosomia. Other risk factors include postterm pregnancy, as we said before, excessive maternal weight gain during pregnancy and maternal obesity, of course, are other important risk factors. Grand multiparity and previous large for gestation age babies are also risk factors. What are the complications? Of course, if you have a very large baby, it's more prone to complications, both the mother and the baby at the time of delivery. The first complication is before delivery. If the mother has uncontrolled diabetes, there's a chance that the baby may die unexpectedly, intrauterine fetal death, and this happens because of the associated metabolic acidosis rather than any Doppler changes. So that if you do an ultrasound and you find that the baby is macrosomic and the mother is found to have uncontrolled diabetes, even if the Doppler appears normal and the fluid appears normal, the baby may die suddenly because of the associated uh, uh, metabolic acidosis. Birth traumas are also more common, such as shoulder dystocia and brachial plexus palsy, because of delivery of a very large baby. The head may pass, but the shoulder girdle may become obstructed above the pelvic brim, resulting in brachial plexus injury. Hypoglycemia, polycythemia, hypocalcemia, and jaundice, these are more common in infants of diabetic mothers because of the fetal hyperinsulinemia and hyperglycemia that result in neonatal polycythemia and hypoglycemia. Maternal complications, of course, if you have a very large baby, you're more prone to do a cesarean section or deliver these patients by a cesarean section. So this is one of the most important maternal complications. If, however, they are delivered vaginally, then they are more at risk of having extensive birth canal injuries, such as complete perineal tears, or later in life, even delayed complications such as stress incontinence and genital prolapse. Postpartum hemorrhage is also more common due to the extensive lacerations that may happen, or atonic postpartum hemorrhage due to failure of uterus to contract after delivery of placenta because of the very large size of the uterus and the large placenta bed area. So how can we diagnose fetal macrosomia? It can be suspected clinically by measuring the fundal to symphysis height or the fundal height, but this is not very accurate because, and it's not of course reliable because it depends upon the maternal body mass index. If you have an obese mother, you may wrongly estimate that the baby is large when actually it's all maternal fat. Ultrasound is the mainstay for diagnosing fetal macrosomia, and this is done by measuring certain ultrasound parameters in the fetus related to the fetal head, the abdominal circumference, and the female length, and we use these to or we put these in a formula, and this formula gives us what is known as the estimated fetal weight. But unfortunately, these formulae are not 100% accurate. There is a margin of error of about 10%. So that means if you estimate that the fetal weight is 4.5 kilograms with a 10% margin of error, that means that the baby's actual weight or neonatal weight may be between 4 kilograms and 4.9 kilograms, which are very, very big margin. But unfortunately, this is how it is with ultrasound. It has a big margin of error of about 10%. This is what a macrosomic infant looks like. You can see here the size of the baby. This is most probably an infant of a diabetic mother. You can see the face, the full cheeks, and you can see the abdomen with very large abdominal circumference. You can also see the creases in the arms and how big and fat the legs are. This is the abdominal circumference, and as you can see, it's a circular circumference. And this is why it is prone to errors during examination, something known as inter-observer and intra-observer variability. And this is why we sometimes get errors with ultrasound that are sometimes even more than 10%. So what should we do if we actually have a macrosomic infant? Induction of labor, if it is more than 37 weeks. This is controversial. If you have a large baby and it is just reaching 37 weeks, you may opt to do early delivery before it reaches full term in order to avoid the baby from getting larger. Of course, if you wait, the baby will get larger and the chances of vaginal delivery will become remote or even non-existent. But of course, if you deliver the baby early, then you're putting the baby at risk of having the complications of prematurity. The safest thing is usually an elective cesarean section. This is usually done, especially in infants of diabetics, because they have large shoulder girdles and large abdomen. They're prone to have shoulder dystocia, and this is true especially if their weight is more than 4.25 or 4.5 kilograms. Vaginal delivery, if attempted, the anesthetic staff and neonatal resuscitation team must be available, and we have to bear in mind that there is a high possibility of neonatal neonatal injuries, especially shoulder dystocia and brachial plexus injuries and neonatal lacerations. Of course, we have to be versed in vaginal instrumental deliveries because many of these pregnancies, if we opt for a vaginal delivery, may require instrumental delivery, but assisted instrumental delivery must be avoided in these cases because they increase the chance of shoulder dystocia. Thank you very much.